It's my pleasure today to welcome Dr. Vaughan Macefield to the Bridging the Body and the Brain Seminar Series. He is going to be speaking to us today about his intraneural microelectrode recordings from the human vagus nerve. So exciting. I appreciate everyone popping on to enjoy this seminar live. It will be recorded and available on our YouTube channel after the session. So you'll be able to return to this recording to gain new insights again and again. As we get started, I encourage everybody to formulate their questions as Vaughan is speaking and pop them into the question Q&A window. At the end of the seminar, I'll present those to Vaughan and we'll have a good discussion at the end of the session. So to get started, I'm just going to give a brief couple of minutes about SPARC, the seminar series, and what you can look forward to coming up next. The next seminar is actually going to be given by me and Dr. Marianne Martone. We're going to be talking about the knowledge base of peripheral nervous system connectivity. That is a SPARC knowledge base that incorporates all of the knowledge related to how neurons are making connections in the periphery so that we can integrate all the data and resources that are available on the SPARC portal. The NIH Common Fund SPARC, which also funds the SPARC Data and Resource Center, which creates the SPARC portal, stands for Stimulating Peripheral Activity to Relieve Conditions. It's an open science initiative dedicated to advancing the understanding of the peripheral and autonomic nervous systems and their role in health and disease. Current research is underway and focuses on the human vagus. Outcomes and data from these comprehensive studies will be shared on the SPARC portal to expand on and augment the science arising from this program. The SPARC research initiatives complement and benefit each other to transform our understanding of these nerve-organ interactions and ultimately advance the neuromodulation field towards precise treatment of diseases and conditions for which conventional therapies fall short. The SPARC portal is a rich ecosystem of tools and resources that allow you to explore the data and models in depth. New apps that focus on the vagus nerve data are in development by the SPARC data and resource teams, and we're excited for this data and these tools to become available. There is a lot of experimental data already on the portal, including over 100 data sets and models that include the vagus nerve. So you can see here that the SPARC portal offers diverse data from many scientists. So in addition to those over 100 data sets and models that include the vagus, we have over 350 data sets total. Across those, we have 65,000 protocol views, over 10,000 data set downloads, over 2,000 SPARC users. So if you attended the seminar yesterday from Dr. Ezra Neufeld and colleagues from the ITIS Foundation, got to see just the power of the surrogate modeling pipelines that they created. We also capture metrics related to dataset citations too. And so we're beginning to really see the efficacy and utility of data sharing as a representative way to expand how we communicate as scientists to each other. So it's not only through experimental publications and research publications and presentations, but now we can really get in and look at the data, understand through the protocols that were created that describe that data, and get to use that data in a way that extends your own research, brings you closer to your colleagues, and facilitates a transformative acceleration for science. That's the overall goal of the SPARC program and the SPARC portal. So our research is designed to provide all of this data together in an integrated fashion. And the SPARC portal is a a domain-specific repository, which means we focus on PNS, neuromodulation, and systems physiology. We are an NIH-approved and HEAL-compliant repository, and you can see that we support numerous consortia, not just the SPARC program and the researchers like Vaughan who are doing research funded by the NIH SPARC initiative, but also 2 individual consortia from the HEAL, Helping to End Addiction Long-Term program, Rejoin and Precision, as well as VITAL, which is an EU funded program focused on creating digital twins. So the SPARC Data and Resource Center can assist with data coordination, curation of these data sets to make them openly fair, accessible, and interoperable. All of that alignment and harmonization means that we can take these diverse data sets that cover physiology to simulations to in-depth histological analyses. So even though we're a domain-specific repository, the modalities that we support are very broad. We are SPARC accepts data from multiple species. It's multimodal, and we bring together code, devices, and wet lab experiments all together to allow you to have that inclusive look of the integrated systems landscape in the PNS. SPARC is an open repository, so we would like you to consider sharing your research and helping to advance this compendium of information about the PNS. We provide professional curation. You can reserve your DOI for your data set. That can go in the manuscript that you're preparing, and it provides a way for you to build your body of work. As I said before, because SPARC is multimodal and multi-domain, you can have your data set that includes your physiology, your anatomy, your inclusion of the simulation models that you looked for efficacy. You can include all of that together, creating that companion to the interpretation of the data that you provide in the manuscript itself. It's a great way to bring those 2 things together. You no longer have to break up your data into individual silos. You can contribute to SPARC, and that can represent the toto of your experimental design. We also offer assistance for grant language, as well as custom services. So if you are a program manager or a group of individual researchers that you want to build a body of work together on, we'd love to work with you. We can offer consortia support as well as individual ad hoc methodologies. In addition to our goal to bring people together over this great research concept, we're very pleased to let you know that we are powered by AWS. We've been accepted into the AWS Open Data Sponsorship Program. And so what that means is that data sets that are published to the SPARC portal are available to access and download and utilize and store for free. So once you contribute to SPARC, your data sets are available for you to use in perpetuity with no cost. I think that that is an amazing gift to you as your future self. So your future self will thank you by being able to have your data in the cloud in a way that you can access no matter where you are in the world. Additionally, we're so thrilled to announce our partnership with Autonomic Neuroscience Basic and Clinical. This is the official journal of the International Society of Autonomic Neuroscience. Dr. Vaughan Macefield happens to have a role in that society right now. And we're really excited about this because we feel that this advances both of our missions to integrate the data deposition as part of your research dissemination process. Bringing it into publication with your interpretation of the data definitely makes your research more transparent and impactful. This is very exciting, and I hope that if you're considering publishing an ANBC, that you also consider sharing your research data on the SPARC portal. And with that, I'm going to hand it over to Dr. Macefield. Welcome, Vaughan.
Thank you. Thank you so much. Sue, let me just share my screen and make sure I have the correct window. Right. Okay, you can see that? Perfect. Thank you very much. Thank you for joining, and sincere apologies again for those who tried to join a couple of weeks ago. Well, you successfully joined. I did not. So my sincere apologies for that. It's nice to see that some friends have tuned in to today as well. So I'm going to be talking about the journey that I took into developing this approach to recording from the human vagus nerve, which is something that I've been wanting to do for many, many years. But where did it all begin? Well, it all began when I became very interested in performing microelectrode recordings from human peripheral nerves. So this technique, known as micronography, was developed by Karl-Erik Hagbarth and Åke Valbo in Uppsala, Sweden in the mid-60s. And it's really provided a lot of information on sense of touch, proprioception, contributed to pain, and especially to control of the sympathetic nervous system. So tungsten microelectrodes, these are insulated right down to the very tip. Only a few microns are exposed of insulation, making them very focal recording tools. It can be inserted into any accessible peripheral nerve, the median or the ulnar nerve, the wrist, the upper arm, radial nerve in the upper arm, the common perineal nerve or tibial nerves at the knee, or the sural or posterior tibial nerve at the ankle. These are all peripheral nerves, of course, supplying muscles, skin, and joints, but there have been a few recordings in the past of microelectrode recordings from cranial nerves, being branches of the trigeminal nerve, so microelectrodes inserted above or below the eye, record from the infraorbital or supraorbital nerve, or even in the mouth to record from the alveolar branch of the trigeminal nerve, or the lingual nerve, or the facial nerve. So this is what it looks like. This is a participant's knee. We have an isolated head stage here, which preamplifies the signal 100 times before this further amplification. These signals are very, very small. We have to amplify in the order of tens of microvolts. So we need to amplify them about 20,000 times. We have an active electrode, in this case, inserted into the common perineal nerve or the fibular nerve at the fibular head, a reference electrode, and a ground electrode on the other side of the knee. And like all electrical signals, we are just measuring the voltage, the potential difference between the active electrode, which is inside the nerve, and a reference electrode, which is under the skin. So here's a schematic of a peripheral nerve. I always show this schematic because it took me so long to make, so it's getting a lot of airplay. But basically, the cross-section of the nerve shows that there are multiple fascicles in this stylized representation. Each fascicle comprises axons, large diameter myelinated axons, small diameter unmyelinated axons, and we can impale individual myelinated axons, and they have a diameter of about 10 or 12 microns, or we can get close to individual or groups of unmyelinated axons, C fibers, as shown in the lower case. So when we record from a myelinated axon with this monopolar microelectrode that's just been inserted through the skin into, in this case, a muscle fascicle of common perineal nerve, we can see that the action potentials that they generate, in this case, we're recording from a muscle spindle, a stretch receptor in the muscle that's responding to applied brisk or slow stretch, or during a voluntary contraction, we can see that the action potentials generated by these myelinated axons generate positive going spikes. Conversely, when we're recording from unmyelinated axons, C fibers, slowly conducting C fibers, which have a diameter of about a micron, we record action potentials that have a negative going polarity. This is important when I start talking about the vagus nerve because, as I've just told you, we can determine the identity of the axon as being myelinated, positive going spikes, or unmyelinated, negative going spikes. We can also record individual C fibers, both sensory and efferent. In this case, these are recordings from individual muscle sympathetic axons, so muscle vasoconstrictor neurons. And this was an approach I developed with Gunnar Wallin and Oke Valbo 30 years ago. Now, the vagus nerve. Well, it's a nerve like any other peripheral nerve, but this is kind of a special nerve, as you all know. It's the largest and the longest cranial nerve, supplies structures in the neck, the thorax, and abdomen. But it's the only cranial nerve which the majority of its innervation to head. Like peripheral nerves, the vagus nerve is surrounded by a thick fibrous sheath, the epineurium, and composed of separate fascicles, each surrounded by a perineurium. And when I started my research career, my PhD, I was recording from the vagus nerve in rabbits, cats, and dogs, anesthetized animals. And I'd cut the nerve under a dissecting microscope and I'd cut through the nerve sheath and split out nerve fibers and put them on hook electrodes under a paraffin bath. So I know that the fiber sheath is very, very thick indeed. So with this in mind, the knowledge of the structure of the nerve, it's just like any peripheral nerve, I reason that it should be possible to impale the nerve in the neck. Of course, this is a bit, this has been avoided in the past, presumably because of, well, the territory of the neck. The vagus nerve runs right along the cranial, the carotid artery, and is posterior to the internal jugular vein. So it's a bit of a dangerous area, as it were. Anyway, in early 2020, we described the first recordings from the vagus nerve. This was in collaboration with a colleague from Pisa, Matteo Ottaviani, who was completing his PhD. He was recording from the vagus nerve in the pig and is now doing his neurosurgical training in Italy. So we performed these recordings in three of us, and then COVID hit. And as you will recall, Italy was the first country after China to report cases. So Matteo had to return home after only a couple of months. So this put everything on hold. But how do we go about recording from the vagus nerve? Well, we use ultrasound to guide a microelectrode into the neck. So we have the neck rotated. Here's the sternocleidomastoid muscle, and we insert it under ultrasound guidance, and we can see it here. The microelectrode, being tungsten, is highly echogenic. So we have to be able to see the microelectrode, and we have to be able to visualize its trajectory and indeed its tip. So here's the internal carotid artery, internal jugular vein. This was one of the early recordings where we went, well, the bifurcation was quite low down. Mostly we're recording from the vagus nerve, where what we see here is the common carotid artery. And this is a video of the microelectrode being inserted into the artery, beg your pardon, into the nerve. Here's the pulsating carotid artery here. This is the compressed internal jugular vein, and this is the vagus nerve here in this triangular region here. So what we aim to do is we're just tracking back and forth. We need to adjust the trajectory of the microelectrode. So it's going to impale the nerve without the internal jugular vein, and indeed without bypassing the nerve and going straight into the carotid artery. Once it's in, and here we see it in situ, the tip in situ, the microelectrode just moves with the carotid artery. We let go of the artery of the microelectrode, and it's just moving with the artery. And this is the same approach if we record from the median or the ulnar nerve in the upper arm. Both of these nerves are sitting on top of the brachial artery, which is pulsating. So we managed to get stable recordings from these nerves in the upper arm, despite the pulsations of the artery, because there is no relative motion between the nerve and the artery. They're just moving together, and this is important. So the sorts of recordings we obtain, this is the a multi-unit recording. So we have this far field activity, which you can see. We have respiration. This is a root mean squared process signal. We have ECG, heart rate, blood pressure. And what we can see is this far field activity during inspiration. But here, here, and here, we can see recruitment of a single axon during inspiration. Now, this respiratory respiratory belt transducer doesn't appear to be reflecting any changes in the depth or the rate of increase in inspiration, but evidently there are changes which are leading to recruitment of this axon. Now, what can this axon be? Of course, we cannot open the chest and poke around as we can do in experimental animals. We have to infer behavior. We have to infer identity rather on the behavior of the axon being recorded. So, what is active during inspiration? Well, stretch receptors in the lungs and airways, but also laryngeal motor neurons supplying the adductors. So, as we breathe in, we dilate larynx. So, posterior cricoarytenoid is a muscle that is the muscle that dilates the larynx. So, this could be one of these axons, a motor axon. But what happens when we take a breath? Now, when we take a maximal inspiratory breath hold, we hold our breath and we do that by closing the larynx. So if that was the case, then if this was a motor neuron supplying the cricoarytenoid, a dilator, it would be silent. But this was active during that breath hold. And this lends support to our idea that this is indeed a stretch receptor from the lungs or the airways. It wasn't a laryngeal motor axon, and indeed it didn't increase its activity during humming, which engages the laryngeal constrictors. This is a recording where we do believe this was a laryngeal, was multi-unit recording supplying the laryngeal constrictors because its primary active was during expiration. Its activity decreased during inspiration. And at this point here, at the asterisk, there was a spontaneous swallow. Now, a swallow will of course, evoke a constriction of the larynx to prevent foodstuffs from entering the trachea, of course. Importantly, though, our next study, following a relaxation of COVID restrictions, this was led by my honor student, Michaela Patros, and we basically wanted to see what can we find in the vagus nerve. We find a lot of silent fascicles, but we find fascicles that are dominated by respiratory-related activity, but we were particularly interested in looking at cardiac related activity because this tells us, of course, that it's something dealing with the heart. And there's a lot of interest in understanding how the vagus nerve controls the heart, obviously, both sensory and motor activity. So this is one of the first recordings where we've got inspiratory related activity. This is inspiration, but we can also find within the same fascicle activity that is uh, discharging in time with the ECG. so cardiac-related activity. We can quantify that by performing what we call cross-correlation histograms. So I'll just take you through this because there are a few figures like this. The black histograms are the autocorrelation histogram of the ECG. So time zero here is the first R wave, and on the right we have the next R wave, and following that the subsequent R wave, and back in time we have the preceding R waves. If this person was on a pacemaker, these would be very tightly locked, but they're not. And so what we have here in the gray are the times of occurrence of the spikes we're recording from the vagus nerve. So I'm showing this to simply illustrate that in these two recordings from two participants, we can see that there is cardiac modulation of the vagal activity. The modulation is higher in the top panel, presumably because we are in a fascicle that has more cardiac-related activity than the fascicle down below. We can also look at respiratory-related activity, shown for two examples here. Same way of showing the data. We can look at tidal breathing versus slow, deep breathing. So we can quantify this. We can quantify this as the peak of modulation versus the trough of modulation divided by the peak. So we can generate a modulation index. We can quantify this. And basically, respiratory modulation is the dominant form of modulation that we see in the vagus nerve. It's much higher, about 45%, compared to the cardiac modulation. Nevertheless, we can quantify cardiac modulation. And as I said, this is something that we're particularly interested in. We sometimes find sites within the vagus nerve where the cardiac modulation is very pronounced. This was the case in this example, where we've got bursts of activity that, to all intents and purposes, look very similar to bursts of sympathetic nerve activity that we record from peripheral nerves. We can quantify it, so we've got very marked modulation of activity. But of course, it is not as marked as the modulation we see, the cardiac modulation of muscle sympathetic nerve activity shown in another participant down here, where we have a we have a dominant peak that occurs about 1.2 seconds following the R wave. This is the well-known R wave triggered delay of the MSNA. So what we see in the vagus nerve is not as marked as what we see with muscle sympathetic nerve activity. We found sites, this is a recent recording, where we have activity in this case, multi-unit activity in negative going spikes, so unmyelinated axons, which have clear cardiac rhythmicity. And this was augmented during slow, deep breathing. It becomes more entrained towards the respiratory cycle. So we got very marked modulation during the peak of inspiration here, and it basically decreases as the during exhalation. And given that much of the vagus nerve is sensory, about 80% of the nerve is sensory, it's more likely that what we're recording is sensory activity coming from the vagus nerve. As I said before, we can't open the chest, we can't poke inside the heart. Ultimately, it would be great to be able to do these during cardiac catheterization, where we can mechanically activate sensory endings in the heart, in the right atria, for instance. But at this stage, we are just inferring the identity of axons based on their behavior and what we know from recordings obtained in experimental animals. This was a very curious recording in which this was obtained in a participant at the end of a maximal inspiratory breath hold. So this is the respiratory phase here, got ECG, blood pressure, and this is where the participant breathed out. But just at the end here, we saw, curiously, these two bursts of activity per cardiac cycle. Now I'll show in the next slide is the same activity converted into a nice figure that was in a recent paper in the Journal of Physiology. So this activity I just showed you, we've got two bursts per cardiac cycle. And what I've done in the lower panel is I've just expanded this section shown here, and I've also shifted the ECG, well, I've shifted rather the blood pressure signal, which we're recording from the finger, back about 150 milliseconds. The reason I'm doing that is to try to convince you that the signal that we're recording from the vagus nerve appears to have these two bursts of activity, one of which is occurring during ventricular contraction, during systole, and the other during appears to be associated with the dicrotic notch, when the valves are closing. So, what could this be? Well, it would appear to me, though we have no evidence, that this could reflect the opening and closing of the tricuspid or pulmonary valves, bearing in mind that we're recording from the right vagus nerve. So, from animal work, that the papillary muscles do have mechanoreceptors in them, and their behavior varies according to where they are located within the muscle, and indeed the orientation of the receptor within the papillary muscle. So we think these are recordings from just chance recordings from mechanoreceptors in the valves of the heart. In 2002, I was invited to Croatia, where they said, "Hey, Vaughan, we love this vagal recording stuff you're doing. Can you come here and record from our breath hold divers? We've got a bunch of them here in Split. They're world champions. They can hold their breath, some of them up to 15 minutes. That's the world record." Anyway, I reluctantly agreed and had to walk along this pebbly beach to the lab every day, which is pretty tough because I'm used to sandy beaches in Australia, but I can't complain. They invited me over, and we did a lot of very successful recordings. People tolerate it very well. Having a needle stuck in your neck, people are still smiling despite this. So we obtained recordings from the right vagus nerve in 21 participants. We were just targeting the right vagus nerve in this case. So 10 healthy young adults, such as this participant, and 11 trained apnea divers, including this guy. And so he's holding his breath. We've got ultrasound gel here. You can see that he's actively holding his breath because the external jugular vein is very distended. The microelectrode is in situ and his lungs are hyperinflated. So what we could record in some examples were, uh, so when they do these breath holds, they hyperventilate and they keep their lungs maximally inflated. But before they reach their break point where they can't hold their breath anymore, they're making these inspiratory efforts against the closed glottis. So there's no airflow, but there are these inspiratory these inspiratory movements. They're involuntary, they can't suppress them, but these are causing pressure changes within the chest. And this is evidently causing this increase in vagal activity, which is sensing those pressure changes. Again, we can do cross-correlation analysis and show that despite these being respiratory movements, they're also causing changes in cardiac activity. These multi-unit recordings from two sites the site in the top panel, the peak activity occurred closer to the R wave, whereas the example below, the activity straddled the R wave. So lower activity during the R wave. What does this mean? It just means that whichever site we're recording from of the nerve, and each area of the nerve is innervating different parts of the heart in this case. We could see that in examples that during the maximal apnea where they're not performing these involuntary breathing movements, so it's purely static, we've got cardiac modulation, and we can see that this is augmented during the involuntary breathing movements. And in some cases, we see just marked cardiac modulation preceding the R wave just during these involuntary breathing movements. And these are all multi-unit recordings. As I said, we don't know what we have, but we're inferring their identity from the behavior of the recording. Be more convinced as to the identity is to record from single nerve fibers, and this is something that we recently published. David Farmer, who's done a lot of work on recording from autonomic nerves in experimental animals, and who is the logical choice for a postdoc on this grant I obtained from Australia. And he analyzed all these multi-unit recordings and extracted single units, uh, 31 of which exhibited cardiac rhythmicity, 10 from the left vagus, 21 from the right. And as I mentioned previously, we could identify them as myelinated axons or unmyelinated axons. So 17 is myelinated, 14 is unmyelinated. So how do we go about this? Well, it's just like any neurophysiological studies where we're dealing with single units. We use a window discriminator. We superimpose a spike, so we know that we're recording from one and only one axon beyond reasonable doubt. We can perform these cross-correlation analyses as you've seen before. Here we have a recording. We've got very marked cardiac modulation. By contrast, the recording in panel D, very little cardiac modulation. So some of the sites that record from the vagus nerve do not have clear cardiac modulation. Some are dominated by respiratory modulation, as mentioned, and some are silent. And we believe that these silent axons are those that supply the gut, which are mostly supplied by unmyelinated axons. Here's a recording that behaved just like a cardioinhibitory neuron. Why do we think that? Well, it had exhibited cardiac modulation and, beg your pardon, let me just go back, and its primary activity was associated during the peak of inspiration. Just in the post inspiration. So it was inhibited during inspiration, where heart rate's increasing, and its peak activity was during expiration, early expiration. And this fits with what we know cardioinhibitory neurons do. During inspiration, our heart rate increases because of a withdrawal of activity going to the heart. As shown here. So its activity is higher during expiration than during inspiration. When heart rate is increases, we want to turn off the brakes to the heart, which the vagus is exerting through these cardioinhibitory neurons to the sinoatrial node. Other neurons behave like atrial baroreceptors. So in this case, during a maximal inspiratory breath hold, we know that this unloads the low pressure baroreceptors, and indeed the cardiac modulation of this signal decreased. So again, we're using behavioral signs to identify the to determine the likely identity of a single unit. So I now just want to talk about what does vagus nerve stimulation has been around since the early 90s. It's used to treat drug-resistant epilepsy in Australia and in the US and many other countries. In the US and other countries, it's also used to treat drug-resistant depression and is used also to treat gastrointestinal disorders. Now, this is a fairly new area of research. Basically, there's a generator within the chest wall, just subcutaneous, and the tunneled through below the skin and wrapped around the surgically exposed vagus nerve in the neck. So there is a cathode at the top, an anode, and a tethering clip in the middle there. However, there's a bit of an art to this. So this comes from the manual, the LivaNova manual, which basically says, okay, when you first implant these electrodes, this is what you should start at. Start at 0.25 milliamps. You can choose 20 or 30 hertz. You can choose 250 or 50, 500 microsecond pulse width. This is a recommended duty cycle, 30 seconds on, 5 minutes off. And we have these auto stims, which were in certain devices, and the user can use a magnet to turn on the device themselves. So if they're having a seizure, for instance, they can turn on the device. But basically, the current intensity and the current frequency are titrated by the neurologist up to levels that the patient rather can tolerate. You want to avoid activating the laryngeal motor axons because that will affect the voice. But despite all this, there are side effects to vagus nerve stimulation. Some people, it causes cough, some people, it causes them to burp, and some people, it causes their voice to change. The Reveal project that I'm part of, led by John Osborne, who's on the call, I'm pleased to see, and some other colleagues there. This is being led by the University of Minnesota, and the aim here is to identify the optimal parameters for stimulating the vagus nerve. As you can see here, there are no optimal parameters, but work that we are doing and many groups in the US that are receiving Reveal funding are doing are to try and identify the optimal parameters by we just vary these parameters, the duty cycle and the frequency, according to fixed randomization process. And one of the things that we're doing in my lab in Melbourne is to record from the vagus nerve with microelectrodes inserted into, so we have a microelectrode inserted into the vagus nerve above the VNS device. This was a preliminary recording from 2 participants. We have data from 4 participants here. What I just want you to show you here is as current intensity is increasing from 0.25 milliamps up to 2 milliamps, what we can see is a stimulus artifact in these 4 participants, this large deflection here. But what we can see are in participant 1, we can see a negative deflection, and in participants 2, 3, and 4, these positive going deflections. The positively going deflections reflect activation of myelinated axons. The negative going reflections, activation of unmyelinated axons. And this was quite curious because at 0.5 milliamps, we can see evidence of activation of C fibers in the vagus nerve. Now, it's quite possible that this was a recording obtained from a fascicle that was very close to the cuff electrode, the cathode, stimulating this vagus nerve. We're not saying that we're getting activation of many C fibers, but clearly the VNS, the clinical VNS, can activate some C fibers, but it's certainly activating many myelinated axons at low currents. And we think this is important for obvious reasons. Perhaps all we need to do is to stimulate the vagus nerve at 1.5 milliamps. We don't need to go up to 3.5 milliamps in some individuals in which we're getting marked side effects. So this will contribute to knowledge about how vagus nerve is used and certainly how it works. We know that VNS is believed to act on the brain through chronic neuromodulation. We don't know what effects it has on other systems, such as the autonomic nervous system. And this is something that the REVEAL project is looking to work out. So one of the projects that we're dealing with is how VNS acts on the sympathetic nervous system. We know that muscle sympathetic nervous system, muscle sympathetic nerve activity, which is muscle vasoconstrictor drive, we can tap into that just with the microelectrode in a peripheral nerve. Plays an important role in the control of blood pressure. We know it's elevated in conditions with very high cardiovascular risks, such as hypertension, heart failure. We know that epilepsy, which VNS is used as a treatment, has very elevated cardiovascular risk. So some people with epilepsy will die, a condition known as sudden unexplained death in epilepsy, SUDEP. So we and partners on the REVEAL project have been recording muscle sympathetic nerve activity during VNS. We've done a parallel study where we've just been applying the VNS according to the participants' settings. But what we showed initially before doing that was showing that people with drug-resistant epilepsy do indeed have sympathetic excitation. They have elevated muscle sympathetic nerve activity compared to age-matched controls. They also have elevated systolic pressure. This is a recording we obtained in our lab at Monash in Melbourne, where we're recording muscle sympathetic nerve activity in a participant who is on the waiting list for a VNS device. So we've got very high muscle sympathetic nerve activity. As you can see here, we're getting bursts of this activity in many cardiac intervals. 3 months after this recording, the activity has gone right down. As you can see here from the root mean square process, this is a baseline. These are the bursts of activity. This is the raw nerve activity, the root mean square or integrated signal. Some people prefer to look at but this simply shows that we have many bursts per cardiac per minute, and it's greatly reduced following VNS. And this also shows that we've got surface electrodes over the neck. We can see when the VNS is on. We see it's ramping up. It's being delivered at 30 hertz in this case and ramping off. And it's clearly not doing anything overtly to MSNA during the period of stimulation. And here is in the same participant during head-up tilt, we've got augmented activity during head-up tilt because we don't want blood to pool in the legs, but VNS is not doing anything acutely. It is reducing the activity chronically, but importantly, it's not doing anything acutely. This is important because we would not want VNS to be turning off our muscle sympathetic nerve activity as soon as we stood up, because otherwise everybody using VNS would faint. And what we've shown, and colleagues in Minneapolis have shown in part of the REVEAL project, is that vagus nerve stimulation does reduce muscle sympathetic nerve activity. So to conclude, we're very excited about the work that we're doing. We certainly encourage others to take up This technique, it's not too difficult. You just have to avoid the carotid artery, obviously. But it's very well tolerated. It's surprisingly well tolerated. People can swallow, they can talk. We just have to keep the head still, of course. We don't want the neck to move. We're now doing recordings from the silent fascicles in the vagus nerve and recording activity coming from the stomach during swallowing. It's a start of a new area of research, and we're particularly interested in looking at signals coming from and going to the heart in health and disease. Um, we've shown that VNS therapy doesn't have any acute effects on muscle sympathetic nerve activity at rest, nor during maneuvers that would increase muscle sympathetic nerve activity, telling us that beat-to-beat control of blood pressure is not affected. But it does show that, as we know, VNS, vagus nerve stimulation, does act through chronic neuromodulation within the brain. And some of that neuromodulation is affecting other systems in the body. It's not just affecting epilepsy, it's not just affecting depression, it has a widespread effects on the body. And members of the team at University of Minnesota are looking at cardiac effects and immune effects, and members of the team at Mayo are looking at effects on the stomach, for instance. And we believe that chronic VNS may have a protective effect on cardiovascular risk by reducing sympathetic overactivity over time, and this may contribute to the risk reduction of DEP. So I'd like to thank the National Institutes of Health for funding this work, and also the National Health and Medical Research Council of Australia, the team, the V team, not V for Vaughan, but V for Vegas, Mateo Devia, Tyder Wood, Leah Wright, Michaela Patros, Dave Farmer, and I can't even see that under there, Keegan Moneghetti, and the epilepsy team, Terry O'Brien, Professor Terry O'Brien, Hugh Simpson, and Shovi Thambu, and just emphasize, as Sue pointed out at the beginning, that SPARC is a wonderful resource, and we'll be sharing our data on the SPARC portal. There's already a lot of data on there, which one can access now. So I'm happy to answer any questions, and thank you for your attention.
Thank you so much, Vaughan. That was incredible. I can't believe that you had to endure walking across pebbly beaches
I know
oh,
it's terrible, Sue, but these are what one has to do when you're a top scientist. It's embarrassing to say, but hey,
I appreciate your sacrifice. And I'm sure the folks on our panel are also keen to wonder how they can sacrifice for science as well
yeah.
in that way. We do have a number of questions, and I invite people to share their thoughts and questions right in that Q&A panel, and we'll get some of Vaughn's reflections on the topics you raise. John Osborne compliments you on your talk and thinks
Thank you.
it's fantastic work. He'd like to know if you could speculate on why chronic VNS lowers MSNA. It has huge clinical implications, excuse me, not cardiac.
Yes, look, it's an excellent question, John, and I really think we'll only find out by doing neuroimaging work. And this is the work, as you know, that Ziad Nahas and Mark George are currently doing in parallel studies. We know that vagal afferents project to nucleus tractus solitarius, the primary receiving area for all these inputs, these visceral inputs. We know that those afferents then project to parabrachial nucleus, insula, various areas. We know that it's a huge connectome, and we've been using brain imaging to look at the sympathetic connectome, but we now need to look at the vagus connectome, the parasympathetic connectome. It's too early to say, but clearly it is interesting that it doesn't, given that it does these afferents project to the nucleus tractus solitarius, it's not engaging baroreflex pathways. Otherwise, we would see this inhibition acutely, inhibition of sympathetic outflow acutely, and we're not seeing that. So it is obviously acting on pathways above the brainstem. And as I say, I think brain imaging is the way to go to understand further how this comes about. But great question. 10 points for you.
Um, we have a question also about Levanova's Anthem HFrEF clinical trial that was terminated in 2023. Jeff Ardell suggested that it was not able to reach neural fulcrum due to using lower amplitude to avoid side effects. You mentioned that 1.5 milliamps
Yeah.
might be sufficient, but Levanova wanted to reach 2 milliamps and higher. Any comments on that trial failure? Any ideas?
Yeah, look, I should point out that, yeah, when I saw the early data, I should point out that this was all done on the right vagus nerve. So epilepsy, pardon me, epilepsy, drug-resistant depression, gastrointestinal disorders. It's always the left vagus nerve that is subjected to the vagus nerve stimulation with surgical implants. And the reason there is to avoid any effects on the heart. This study, the Anthem study, and some parallel studies were targeting the right vagus nerve. And they certainly did show that there was a reduction in heart rate and an improvement in cardiac function. And I've got many cardiologist colleagues who were so disappointed that this trial was terminated, and they all agree that it should be resumed. So this was specifically looking at people with heart failure, and again targeting the right vagus nerve. And just to emphasize that this was a specific trial looking at heart failure. Um, with respect to the currents required, well, the axons that you want to stimulate there are the cardioinhibitory neurons, those going to the sinoatrial node, which are myelinated. So you should be able to activate those at currents of 1 to 1.5 milliamps, as we're now showing from our vagal nerve recordings. C fibers, I mean, the ventricles are innervated by many vagal C fibers. You may need higher currents, but again, we've shown that you can activate some C fibers in the vagus nerve at low currents. So, yes, I think they should do another trial, bring it up to 2 milliamps and see what they get, because I think it's a missed opportunity to have stopped that trial.
Very fascinating. Thank you for your reflection on that. I think we have time for one more question. And you mentioned that some of the work that you started with this microneurography in the vagus nerve was interrupted by COVID.
Yeah.
And so a question was raised about whether or not you've been able or interested in recording in patients who are suffering from long COVID. Any thoughts?
Look, that is a very good question. We're currently doing, and we have been doing, studies with Erin Howden at the Baker Institute in Melbourne, and we've just got funding from Australian funding agency to do further work on long COVID, specifically brain imaging and lower body negative pressure in the scanner, but not vagal recordings in these participants. It would be interesting. Look, it's a good point. We're not currently doing that. We're doing recordings of muscle sympathetic nerve activity from the common peroneal nerve, and we're doing that at the same time as imaging the brain at 7 Tesla, so we can identify all the sites within the brain that are affected by the sites rather that generate the sympathetic outflow and are potentially affected by long COVID. But we're not currently planning to look at the vagus nerve, but it is a very interesting question.
All right. Well, thank you very much. And Vaughan, I just want to thank you for sharing your research today, giving us some insight into how you're thinking about the function of the vagus nerve, both sides actually, left and right, and the opportunities that this technique offers to enhance our understanding. I appreciate the international collaboration that you and your colleagues are demonstrating so well, and the work that you're doing on the Reveal project, and we can't wait to see more. That data that you are doing for the Reveal project, as well as other phase 2 studies that are devoted to the vagus nerve, will all be contributed to the SPARC portal in the coming months. So we really are very excited to have all of the data come together so we can all swim in all of that knowledge. So thank you very
Thank you
much.
very much, Sue. These are very, very exciting times, and I'd like to thank everyone for joining. And feel free to contact me if you have any questions on vagal micronography. Thank you so
Spectacular.
much.
Take care, everybody.
Bye bye.